Hi, everyone, and welcome to today's webinar on our 2023 calendar, Brain Injury, Overdose, and Harm Reduction, offered by the National Association of State Head Injury Administrators. Thank you so much for joining us. I'm Maria Crowley with NASHIA, who I'm going to be your organizer for today. Anastasia Edmonston with Maryland's Behavioral Health Administration is going to be your moderator. Closed captioning is available by enabling at the bottom of your viewing window. If you need any assistance for today's webinar, please send us a chat through Zoom or go to Zoom's support site. Questions for the presenter can be added to the Q&A in your viewing window. We'll address those questions at the end of the presentation if time allows. A little bit about NASHIA. We're a nonprofit organization created to assist state government in promoting partnerships and building systems to meet the needs of individuals with brain injury and their families. We're a membership organization as well and offer several different membership categories. Please visit our website for all the available options. There are many benefits to membership, including a connection to our directory. If you have any questions, feel free to email us. In addition to numerous training opportunities, NASHIA offers technical assistance and consulting on a range of topics. You can find out more by emailing us. General certificates of attendance and social work CEs are available for today's event. You'll receive an email tomorrow with a link and a general feedback form. There'll also be a link in that email for your certificates of attendance. Members, as a benefit, receive certificates of attendance free. And if you need that, contact Amanda Neeser at NASHIA.org for your complimentary certificate promo code. The certificate, the evaluation links, and a recording will also be available on our website for later access. For viewers of the recording, please go to Trainings on Demand to find information on how to obtain your certificate. I would now like to introduce you to today's session and to our moderator and presenter. Harm reduction is a set of practices that help people behave safely while also shifting systems and environments to be safer. Harm reduction recognizes that society and the systems within have historically put people who use drugs or engage in sex work and more harm through oppressive policy and stigmatizing culture. Today, you're going to get an overview of how people with brain injury can be better supported in terms of reducing risk and some examples about how to apply academic detailing. We'll have some discussion about how state and community partners can be invited to the table as well in your own state. So without further ado, I'd like to introduce Anastasia Edmonston, who's our moderator for today, who, as I mentioned, works for the Behavioral Health Administration, and Laura Bartolomei-Hill, who also works with Maryland's Behavioral Health Administration. And a little more about Laura. She's a social worker by trade. She works in Baltimore City. She currently works in multiple clinical settings, including an assertive community treatment team, outpatient substance use disorder services, and community-based sterile syringe distribution. She also works with Maryland's Department of Health on the TBI Partner Grant. She's part of their advisory board and works with, obviously, with Baltimore's Harm Reduction Coalition. Welcome.
Thank you. Okay, I'm going to switch over to share my screen, hopefully successfully. No?
Almost.
Okay, let me try again.
Okay. Let me make sure.
It says my screen sharing is paused. Resume share.
Let me just quickly check and reset that for you. Now then, let's try that again.
Okay, there we are.
There we are.
Okay. Hi, everybody. Good afternoon. My name is Laura. I'm a social worker here in Baltimore City and working with the Maryland Department of Health Behavioral Health Administration to do some trainings on brain injury, harm reduction, and overdose. So I'm going to run through my slides. Please feel free to put any questions into the chat, and we'll see if we can address things as we go. Okay. Okay, here we go. So we went over my little bio. Okay, so today we're going to define and connect overdose, opioids, and brain injury. We're going to introduce some harm reduction strategies and principles. We're going to talk about overdose prevention sites specifically and consider supervised drug consumption as an evidence-based practice, making some connections between overdose prevention and brain injury prevention. And we'll spend a little bit of time talking about stigma and criminalization. So just to start out with, I'm going to start just like doing some really brief introductions about what overdose is and some of the basic connections between overdose and brain injury. So specifically today, we're going to be talking about opioid overdoses. So an opioid overdose, been in the news a lot over the past decade. It specifically is about negative health consequences caused by taking too much of an opioid. That can be alone or in combination with other substances. The way that an overdose causes long-term effects, which include brain injury or death, is through the suppression of breathing. And so taking too much of an opioid causes the breathing to stop. And that this can lead to unconsciousness, coma, brain injury, and death. And surviving an overdose depends on restoring respiratory function and getting enough oxygen to the brain. So that could either be through naloxone, which is a medication, or through rescue breathing or supplemental oxygen. Naloxone is, I'm sure many of you have heard of it. It's a safe medication. It's used to reverse opioid overdoses. It's available in various formulations, including intranasal, intramuscular, and intravenous. It's available throughout the country, often to community members through pharmacies and other distribution programs. And it's most effective when individuals who use drugs are prioritized in outreach efforts. During the pandemic, overdose got a lot worse, which was, not surprising. There were a lot of disruptions in-person treatment, and a lot of programs went virtual. A lot of people experienced worsening life stressors, including around housing, employment, health insurance. Social distancing meant that people are often alone, and there might be fewer people around you to respond to an overdose. Very difficult to, to administer Narcan or rescue breathing to yourself. And so that kind of social isolation made people a lot more vulnerable. There were also some disruptions to the trade patterns, migration at the beginning of the pandemic, which made the drug supply a little bit less predictable. And if you're less confident about what specifically you're putting into your body, then you're not as able to prepare for what some of the side effects might be. This is just an image in Maryland. It's from 2011 to 2020, so not even taking into account the changes from the pandemic. But you can see the red line is a pretty significant increase in opioid-related deaths over the past decade. I'm sure many of your states have similar graphs, unfortunately. So I'm considering our focus today is primarily going to be on overdose, which is considered an acquired brain injury. And so specifically today, thinking about anoxic and hypoxic injuries as caused by opioid overdoses. Just like other types of brain injuries, and a brain injury from an overdose can be chronic and can get worse with age. The frontal lobe is highly susceptible to brain hypoxia, to that reduced oxygen, and that the frontal lobe damage can lead to potential loss of executive functioning. And a lot of those executive functioning skills are what's required for successful participation in treatment. People who are in like current models of substance use treatment. So some people might be, survivors of an overdose, might have difficulty with following rules at your program, with coming to appointments on time, general lack of engagement. And there can also be a decreased ability to participate and engage in treatment in that program that puts people at an increased risk for relapse. Today, because we're focusing on brain injury, we're really going to be thinking about non-fatal overdose as where the focus of our attention might be. So according to the White House dashboard, there were a little over 200,000 non-fatal overdoses in the past 365 days. This likely does not include the number of people who were revived in the community by family or friends, or first responders for people who decline transport to an emergency room. So you can imagine that very few of the individuals likely who show up in an emergency room with an overdose or who are revived by a friend or neighbor in their community, very few people are screened for brain injury and very few people are eventually referred for brain injury services. So this is potentially a massively underserved population of people who are not necessarily being identified or screened appropriately for this injury. These are some common challenges after brain injury. I'm sure many of you have seen a lot of these in the past. I think when looking at this list today, I specifically want to think about how challenges in this area might make participation in traditional substance use services challenging. So many substance use services currently utilize a model that involves group settings. So you can imagine the difficulty of sitting through an hour-long or multiple hour-long group therapy sessions every day when you're having issues with disinhibition or impulsivity or fatigue and exhaustion or difficulties concentrating. So a lot of our substance use services are not necessarily developed with these type of issues in mind. And just like other types of brain injury, multiple overdoses can have a cumulative impact. And so subsequent brain injuries can take longer to resolve, and the individual might experience more severe or different symptoms. And then we also have to consider, like, what does it look like if someone has a quote unquote near overdose? If breathing slows but doesn't completely stop, what are some of the long-term effects of this type of regular oxygen deprivation to the brain? So in addition to, there are some healthcare considerations that are not related to overdose. Injection drug use without sterile equipment can contribute to development of abscess and wounds. And chronic wound care can require a high burden of health management. So you can imagine, taking care of a wound on your hand that needs to be covered all the time when you're also dealing with potentially a co-occurring brain injury, as well as, potentially active withdrawal, as well as other psychosocial stressors. It can be extremely difficult and very complicated to manage these types of wounds long-term. And there are significant risks, particularly infection or possible death if done inadequately. There are also adulterants in the drug supply right now. There's one particular called xylazine that's particularly prominent on the East Coast. That can also be linked to the increased prevalence of ulcers and soft tissue wounds. So again, thinking about that co-occurring issue of, just like with other types of brain injuries where you might have physical injuries as well as an injury to the brain, when we're thinking about substance use, there can also be that co-occurring issue of both an overdose risk as well as managing some pretty complicated wound care and healthcare issues in the context of that brain injury or potential brain injury. Okay, I ran through a lot. I'm just going to stop and see if there are any questions or anything here about this. How are we doing?
Laura, I'm not seeing anything in the chat. I have requested folks put questions in the Q&A because we have a lot of people letting us know who they are and where they're from. I don't want questions to get lost. So if you do have a question for Laura, put it in the Q&A. I'll be sure to see that. Thank you.
Okay, perfect. Thanks, Stacia. Okay, so we're going to jump now into harm reduction. I'm sure many of you have heard of harm reduction. I'm going to share the particular definition that I've been using to guide my own work, and it comes from the Baltimore Harm Reduction Coalition. So, this is one definition of this, and hopefully, it's something that resonates with you as well. Okay, I skipped too many. I got too excited. Okay, so harm reduction. So the definition, like I said, it comes from the Baltimore Harm Reduction Coalition. And it reads that harm reduction is a philosophy as well as a set of practices that are applied to particularly stigmatized behaviors such as sex work and drug use. Harm reduction is practiced on two levels. So interpersonal level, that's the level that is the most commonly associated with it. This might include changing routines, sharing resources, distributing tools for increasing safety. And we also have to think about this on the institutional or on a political level, where we're changing policies and systems to support safety and decrease violence and marginalization. So we're going to break these two down in a second on the next couple of slides. So interpersonal harm reduction, that's me at the beginning of the pandemic. You can tell it's early in the pandemic because I'm wearing a mask outside. But here we are. And so this is interpersonal harm reduction is often thought about like naloxone distribution, sterile syringe programs, needle exchanges, distributing safe sex kits, using fentanyl test strips, overdose prevention sites, these types of interventions. So very much a, just distributing things between individuals. So in this picture here, I am working at a syringe service program in my neighborhood, which I was just at earlier today. And we're giving out various types of syringes as well as other materials for safer drug use, including alcohol pads and cottons and cookers and other types of materials. These types of materials are specifically used to decrease the spread of infectious diseases and also to decrease the prevalence of those types of wounds and abscesses that we were talking about earlier, which can be so difficult to manage. If someone is reusing the same syringe several times, you're definitely increasing your risk of an abscess. And so by providing sterile equipment, we're reducing the prevalence of HIV, reducing spread of Hep C, and hopefully reducing prevalence of wounds. It also works as a way of bringing people into services. I have helped some of our clients access hospital-based wound care on multiple occasions. I have helped people get into different types of treatment programs, navigate issues of domestic violence hotlines. So it's definitely a way of accessing services for people who have often been marginalized or have experienced a lot of discrimination or stigma inside of traditional healthcare settings. So that also leads us into talking about harm reduction on the institutional level. This is sometimes also considered harm reduction as a political or social movement. And so it is helpful to remember that harm reduction started as a political movement during the time in the 80s around HIV and AIDS advocacy. And so it's always been grounded in this sort of political movement and this idea of increasing safety and advocating for healthcare services for people who have traditionally been marginalized by this healthcare system. And so when we're thinking about harm reduction on the institutional level, we're challenging, we're looking at our policies and our organizations to identify the ways that our organizations and our societies might be doing harm to the people that we're working with. And so some of the ideas that I have here for ways to practice harm reduction on an institutional level include advocating for increased access to healthcare, reconsidering the severity of punishments for individual behaviors, including drug use and sex work, and assessing how your agency or organization might perpetuate stigma and making an action plan to change the cultures and practices. At the Suboxone program, which is the substance use service program that I work in, a few years ago, we did sit down, we reviewed all of our programs and policies, and we realized that several of the rules that we had were making it more difficult for people to access services, and we're not actually helping anyone. And so we had the opportunity to work with our clients and to use a harm reduction guide to help figure out how we might be able to improve some of our services and thinking about what ways were we as providers actually doing harm or perpetuating stigma, even unintentionally. So it can be very difficult to access healthcare when you have a history of drug use. If history of substance use is listed in your medical record, or if you are showing up with and you take a drug screen and it comes up positive for things, that can really change how people treat you inside healthcare settings, particularly hospitals or other outpatient clinics. There are oftentimes concerns or issues might be dismissed or attributed to what's called drug-seeking behavior, which is oftentimes where people will say, oh, people are presenting in this way in order to get some type of secondary gain. You might hear statements from providers that say things like, you deserve this. I personally took a patient to the hospital for treatment of an abscess. It's a hospital that I'd worked with before, and the surgeon straight up told him, like, you deserve this, which was very hard to hear. And it's not an easy thing for someone who's like trying to enter a space in which they don't necessarily feel welcome. There can be poor management of withdrawal or continuation of medication-assisted treatment. And so this kind of goes to the one above it about this feeling that like you deserve to suffer a little bit if you are coming in with a history of drug use. And then feelings of being dismissed or being judged. And that this stigma is often related to drug use, is often held up through criminalization. So those two kind of things go hand in hand. One opportunity for intervening here is what I'm calling academic detailing. It's kind of an adaptation of what academic detailing is like as it's currently used. So I'm not sure how many people have utilized this intervention. I think it's a really cool opportunity, and I hope that it can be a little bit more widespread. But academic detailing is peer-to-peer outreach between healthcare providers. So at its inception, it was specifically between physicians for their purposes of improving patient care and prescribing practices. So it'd be a doctor reaching out to another doctor, or a nurse reaching out to a doctor, you know, real peer-to-peer to talk about how to improve those prescribing practices. Maryland has, through the health department, coordinates an opioid academic detailing project that gives personalized individual education to providers. So this really stuck out to me because I'm sure, like many of you, I'm a social worker. I go to like my CEU trainings as well. And a lot of the times I'll hear people talk about things and I'll be like, that would never work where I work. Like, it just wouldn't work. It's really cool that they're doing it. Wouldn't work where I work. And in my head, this is an opportunity to follow up on these types of trainings with really peer-to-peer support for being like, okay, so maybe it doesn't work exactly like this, but how can we adapt something like this into this program? It also connects providers directly for peer support for the purposes of improving care, problem solving, and sharing other ideas. Okay, I'm going to stop here. I see we might have a question, Anastasia. And I know I've been talking a
Yep,
lot.
sorry, I was muted. So Lynette says, my 48-year-old son suffered a anoxic brain injury May 2017 and is now on a feeding tube 100%, having dysphagia. He wants to be able to pass his swallowing test next month. He was an alcoholic, but has not had any alcohol since his TBI. He's at risk of aspiration, and the facility he is at is reluctant to allow anything by mouth. I have an appointment now, but I would like to follow up with you for suggestions. Thanks.
Yeah, I think it's a really difficult situation. And yeah, I'm happy to follow up with you after this. Okay, we're going to talk. Oh my gosh, how do I get this out of me? Okay, so specifically, we're going to move on to talking a little bit about overdose prevention sites. I consider overdose prevention sites to be specifically to be considered within the context of a brain injury prevention intervention. So overdose prevention sites are a little bit less probably common than, definitely less common in the United States, but are less commonly well known. So we're going to run through them pretty quickly. So overdose prevention sites are safe and private places for people to consume drugs and receive life-saving interventions in case of an overdose. They're able to access sterile equipment and can receive referrals to healthcare services, including mental health care. There are over 200 overdose prevention sites in 14 countries, including in the United States. And the very first and still only public site in the United States opened in December 2021 in New York City. So from the literature, these programs have been extremely well studied, particularly in Canada, where they're quite prevalent. So overdose prevention sites have been found to increase connection to substance use treatment programs, to prevent overdose death, connect medical providers and advocates for support in seeking healthcare, reducing public drug use, reducing public syringe litter, so it's like finding needles outside, reducing transmission of Hep C and HIV, increasing capacity for EMS to respond to other emergencies, and creating a space for safety and acceptance. If we're often thinking about overdose and addiction occurring in the context of isolation and shame, then it can often be that creating a space where people feel safe and accepted can be very meaningful. So I had the opportunity to visit the two overdose prevention sites open in New York City this past fall. So since opening in December 2021, they've had just over 3,000 participants who have visited the site, and they've had over 800 overdose interventions since that time. So when they're saying overdose interventions, that means that someone on their site who's engaging in like the supervised drug consumption program they've been able to receive microdose Narcan. So this means that, if you're carrying around naloxone, as part you got from the pharmacy or from the health department, it's often coming in doses of 2 milligrams or 4 milligrams. But because they're able to do constant vitals monitoring and like respond very quickly, they can microdose Narcan. So you can get like 0.4 instead of 2 milligrams. And so it makes the experience of coming out of an overdose much gentler. They're also able to provide supplemental oxygen. So if you're thinking about brain injury intervention in terms of reducing the length of loss of consciousness, then, I mean, this is a pretty immediate, this is a pretty dramatic drop, right? So, you know, say in the community, someone sees someone who's passed out, you don't necessarily know how long they've been unconscious or have lost consciousness. Even if that you call EMS, that's still potentially a 15 to 20 minutes away from receiving oxygen. And when in these overdose prevention sites, it's seconds, you know, it's seconds from the time when someone loses consciousness to the time when they're receiving supplemental oxygen. It's an immediate response, and they're able to keep track of everybody's vitals during this time. And so if we're thinking about overdose as a brain injury, as, you know, an overdose prevention as brain injury prevention, this is a pretty immediate intervention in terms of like reducing, I mean, this is potentially 800 brain injuries, you know, people who are at risk for 800 different injuries that perhaps didn't, you know, didn't have those symptoms as a result. It's also improved syringe litter in public spaces, including at the schools and parks in the area. So the supervised drug consumption is just one component of the services at this location. So it's an expansion of an existing harm reduction drop-in center. The services include meal services, sterile syringe supplies, referrals to substance use treatment, laundry, clothing distribution, showers, a health suite with medications for opioid use disorder, treatment for HIV and Hep C, mental health counseling, acupuncture is a nice garden. And so it really goes back to this idea that harm reduction is not just the sharing of tools. It's also, you know, there's an institutional and a political component of this that is about creating places where people feel safer and more accepted. And then overdose prevention overdose prevention sites can function as brain injury intervention. So the staff are trained to recognize and immediately respond to overdoses. The capacity to provide immediate response to an overdose reduces the duration of loss of consciousness. There's a reduction in occurrence of anoxic or hypoxic brain injuries, and the escalation of care can happen much more quickly if it's needed. Okay, so the question.
Yeah.
Do people live there? So people don't live there. It's not open 24/7. It is open, I think, until midnight in New York. But you're right, there is that continued, you know, it's not a service that's available 24/7. So it isn't. So basically you can go in, you sign up, they have you like write down what supplies, what you think you're going to be using. You have the opportunity to, they'll assist you in testing your supplies. So if you want to, you know, if you got something off of the street and you want to know specifically what is in the supply that you'll be using, you have the opportunity to test that. They set you up with sterile equipment in a safe place. And then you can use your supply while you're there. And then you can either hang out in the room, or they have like a hangout room that you're welcome to go spend some time in. And then, yeah, and then you can leave whenever you want to. You can access the other services, or, you know, you can leave the building. I would say 90% of the people there are accessing other services while they're there.
Laura Kelly Ramsey, who is a physician who works in New York State Addiction Services, said that NYC, New York City, is planning to expand. So that's good news.
Yeah, that would be wonderful. Okay, what did I do? Okay. Does anyone have any questions about this section? Does this make sense? Any other thoughts? Mm-hmm. Okay.
Sorry, I muted myself. Laura Holmes also had a comment about, do police monitor the place, or how are they kept safe, meaning the individuals that are at the sites, from being targeted by law enforcement? Yeah,
that's a great question. So I think so the situation in New York City is that it's not necessarily, so you know, supervised drug consumption has happened across the country in formal and informal ways, in communities taking care of each other, as well as in kind of like more underground sites that are more staffed by healthcare providers. So New York City is, we call it the first like public drug consumption, supervised drug consumption space in the United States because it's the first one with a website. You can find their hours and their services and they're published online. And they're able to do that by working together with the state's attorney in New York and the mayor and the governor, but they don't have a statute. And there's not like a federal law that permits this right now. I think Rhode Island has a state law that permits it, but I don't think they have any sites that are currently operational. And so that means that there is a continued risk for involvement with the police. I think that, so there is some risk. I think that they haven't had any issues at this time, and they've mostly had a lot of cooperation with the police. Particularly when they said they've had some instances where police will have brought, there's a couple of parks near their sites, and if people are using in the park, the police will like kind of bring them to the site instead of as a way of being like, can you just use inside?
Laura, there's one more question. I'm sorry, excuse me. How are these sites being funded?
Yeah, right now it's all private funding. So there's no, I think that there are, so it's a little bit complicated because this is one service in a broader like healthcare center. And so the different services can be funded in different ways. I think specifically and I might be wrong about this, I don't work at the site in New York. I know that in our site, at our needle exchange, where we don't do supervised drug consumption, but where we do syringe services, there are certain supplies that the state will pay for and certain supplies that the federal government will pay for and certain supplies that we have to get privately funded through like grants or fundraising. So there are some restrictions on what federal funds can be used for and what state funds can be used for. But it's like a little bit, it's not like a very straightforward answer. But so I think a combination of like federal, state, and private funds, depending on what the specific service is and how legal it is. Cool. Okay, great. So anyway, so my main takeaway from this that I just wanted to share is specifically thinking about some of these harm reduction strategies as brain injury interventions and as brain injury prevention. When we're thinking about, that number that I shared at the beginning of over 200,000 people having a non-fatal overdose in the country in the past year, thinking about how many of those interactions or how many of those brain injuries could have been responded to more quickly or had the impact lessened as a result of a more immediate intervention, the type of which is often available in an overdose prevention site. Okay, so I'm going to transition. I just have one little more section for us to get to before we have question and answer or like a little bit more open conversation. So I think I just have like 5 or 6 slides left. So the last section I wanted to talk about, and this is something that I think that all of you who are working in brain injury work probably are also experiencing and have a lot of expertise in. But I wanted to add a section here on keeping up the energy when this crisis seems never ending, because it doesn't seem like it's getting better, and it's very emotional and intense work. And so, I just wanted to spend a little bit of time talking about how do you keep your energy up and how do you keep your motivation going when it just feels like you're like in crisis mode, but like for a decade or a lifetime. So burnout is the mental and physical exhaustion that can lead to reduced accomplishments and diminished sense of identity. It can lead to feelings of apathy and disconnection from your purpose and from your work. I'm sure a lot of people on this call have experienced some burnout, either in their professional or in their personal caretaking responsibilities. I will often say that I would always say like self-care is not enough. And I personally don't like it when my managers will ask me about my own self-care practices. Rest and leisure time are very important for the purposes of being a human being existing in the world. but how are we building and creating work environments that stress us out less, that cause us less harm? And for me personally, that often comes down to like having support when my patients are really having a difficult time, or having a manageable caseload, or like a manageable amount of responsibilities, or good health insurance. And so when I think about what self-care looks like for me at work, a lot of the times, instead of, me being like, oh, I like to garden, or I'll go for a run, I'm thinking about like, how can we make work less stressful so that I'm not spending all my personal time coping with the stress that happened at work. So I'm going to open this up for, if in the chat, what are some of your strategies for coping with burnout, and what does burnout feel like to you, and how do you support yourself and others when you're experiencing it? Okay, we'll just think about it. I'm going to move on to I have a few of these where I'm like, I'm interested in hearing people's thoughts because I haven't figured it out, obviously, but so I'm going to move on to the next one.
Laura, there is a comment in the
yeah.
chat from Carrie that said we're not responsible for the outcome of our efforts, and that's a good reminder when I'm working harder than my clients to get better.
Yeah, for sure. That's a good point.
And then refilling my cup with activities I like. That's a good one.
Yeah.
Breathing techniques, also meeting with other social workers to talk about it.
Yeah, that makes a big difference.
Outside activities in the evening, sports teams and joining clubs, shutting down our work phones when necessary and appropriate.
Yeah. I have declined 4 work calls since I've been on this webinar, so. Okay, I'm gonna move on to the next one. The next one is about anger. I feel like anger gets a bad rap, but I think it's actually a pretty important feeling, and one that I'm sure many of you and I feel all the time, especially when trying to navigate the healthcare system that we currently have in the country to get quality healthcare for the people that we love. So anger can be, so when I try to think about anger, I try to think about it as, and I remind myself that it's often existing or can exist when I'm feeling most powerless, and when I'm feeling most powerless. And that it is often something that can communicate to me when I'm feeling disrespected, or when I'm feeling like a situation is being neglected. And so, a lot of the clients that I work with will say like, I need to work on getting less angry. And I'll be like, yeah, I can understand that. But it's also about listening to what your anger is telling you and trying to be more intentional about how you're taking that in and how you're listening to that. I know that for me, like it genuinely makes me very angry when my clients are disrespected at the hospital, or when I feel like people aren't being listened to, or because that, that like when people aren't being listened to, the consequences for that could be huge. Like if someone is being dismissed or condescended to or not listened to when they're in the hospital, that person might leave. And if they don't seek medical treatment, the consequences of that could be life-changing. And so for me personally, I have tried to come to terms a little bit with like how I use anger and how I react to it, and embracing it a little bit in the work that we do, because I think that feeling angry makes sense in a lot of the settings that we're in. So I'll give you a second to like think about that, and if that is anything that I don't know, something to think about. I'm gonna go on to my next one, and then maybe we can like, oh, anger is your biggest motivator. Oh, I love that. The day I stop being angry, I'll step away from harm reduction. Yes. Underrated. I also I wanted to include in here, I have used this for myself. This is the dual process model of grieving, which is a a grief model that I've used to think a lot about both loss and when people, there's a lot of death that occurs or loss that occurs when you're working in spaces of brain injury and overdose and harm reduction. So for me personally, this is the model that has been the most helpful for me in coping with some of that. So the dual process of model of grieving says that we have two types of orientation. We have a restoration orientation and a loss orientation, and that the healing occurs in the oscillation between those two orientations. So going back and forth between those two things. So the loss orientation is the time that you're spending with your grief rituals, with your emotional processing, with missing the person, remembering the person, experiencing some of that, the distress. And then the restoration orientation is about how is that loss changing you? How is it requiring you to develop new skills? Like if you always relied on that person to do something, is that a thing you're going to have to step into doing? How are you taking this experience and learning new things from it, or experiencing some psychosocial stress or transitions through it? So I just wanted to share that because it's been something that's been helpful to me. And I don't, my own personal experience in harm reduction has been that it has been an amazing opportunity to feel connection and personal growth and really connect with my communities and the people around me. And it has also been one that has been filled with quite a bit of loss. And so I think that like remembering that we're all humans, even when we're at work, is very helpful for me. I think that I have one more slide. We'll see. Oh, wait, no, I have one more. Where is it? Okay, here we go. So this is something that other harm reduction people I'm sure are familiar with the work of Adrienne Marie Brown. She wrote a book that I really loved called Pleasure Activism. And what she talks about in her book is that what feels good is sustainable. And I think that what really resonated with me about that is that this idea that even in the hard work that we're doing, it's about focusing on those opportunities that what about the work feels good. And in general, like seeking healthcare and improving your life, whether that is by going to a harm reduction program or seeking brain injury services, like this should be a pleasurable experience. Like people should be feeling good when you go to the doctor. And I think that we're so much focused a lot of the time on deficits and on symptoms and on so much of the negative components of this. But like truly what is going to keep someone coming back to services is that they feel good when they're there, that they feel seen, that they feel listened to, that there's some enjoyment, that they can laugh, they can have a good time, that it feels meaningful, and that what feels good is going to be sustainable. And so finding ways to make the work that we're doing feel meaningful and feel enjoyable is for me the part that helps me navigate this piece about burnout the most. The last thing I wanted to close on, this is from a book called The Happy Runner. I do a lot of running, and I read this book when I was at a particularly low motivation around my running. And I found it to be this framework to be so helpful. And I have tried to adapt it from just the context of running to my life. And I think that and to the work that we're doing. And so I just wanted to share it with you. So they propose that you ask yourself and reflect on 4 questions. Why do I run at all? So why do I do this work at all? Why do I run every day? Why do I do this work every day? What is bringing me to it every day? Why am I racing? Like, why am I having those big moments that I'm working towards? And why do I have long-term goals? And so even though, this was developed for the purpose of like motivating you to exercise, but like, I think for me, this really comes down to it. Like, what is my purpose in this? What am I getting out of it every day? What am I working towards? And what are some of my long-term goals? Wait, did I lose my screen sharing?
Yeah.
I did. Are you seeing my email now?
Yeah, I can see my email to you,
Cool.
or you to me.
Hold on, let me put it back up. I don't know where it went.
I don't know what happened there.
Okay, I'm doing it. I'm going back.
Okay.
Okay. I think I feel like I haven't done it yet.
No, we're not seeing it yet.
Okay, I'm doing it. There we go, right?
Yep, just put it in the slideshow.
I just have one more slide. Sorry, everyone. Come on. Okay. So yeah, so like thinking for yourself, like what brings you to this work at all? What brings it to you? What do you get out of this every day? What's your purpose in doing in those kind of like more intense sprints? And what's the purpose for your long-term goals? And so this has kind of helped me give me a framework for like both like my outcome-based goals and my process-based goals, and has just been something that I have appreciated. So I always close with this quote by Audre Lorde, because I think for me, it really captures what I'm hoping to do with my harm reduction work. And I think that what I feel like I'm doing my best to work towards, which is that, as she says, and that deep and irreplaceable knowledge of my capacity for joy comes to demand from all of my life that it be lived within that knowledge that such satisfaction is possible. And I think so many of the people that we work with experience so much stigma and so much shame and so much marginalization, that the idea of that I want people to have an experience for how much joy and how much love they have the capacity for, and to come to demand that in all the settings of their lives. So I'm going to close there. And I think we have like 15 minutes for any like comments or questions. And then any thoughts. I know that I think at the end, like, what feels good for you in your work? I'd love to hear a little bit about like what feels good for you in your work, as well as any questions you have. So I'll leave this one up, and then, or I guess we can close it, and then I can stop sharing.
Yeah, you could probably stop sharing. The only thing I would add is maybe put your contact information, your email, in the chat. So if people want to touch base with you, because it was on the last slide.
Okay.
So
I can do that if you guys want to address questions.
Hey, thanks. Yeah, I didn't even do it right away. But yeah. So Patricia has, thank you, Maria, has put a question in. Is there any system out there that currently links those who have had an overdose to brain injury services if they display symptoms?
I don't think there's a specific brain injury. I think it would just be about including people who have experienced overdoses in other types of brain injury services. I don't think, at least to my knowledge, other people might have more experience with that.
Yeah, I think that what we're doing in Maryland, at least, is trying to educate folks across systems, so people in brain injury will understand a little bit more about substances and harm reduction, and that people who work in harm reduction and substance and mental health treatment understand a little bit more about brain injury. So trying to do that cross training. I also want to mention Helena made a comment. It often takes a while to come to terms with anger and figure out what I can do that would be helpful in a situation. So is there a screening tool available for substance use treatment we can use with clients?
I'm not sure what type of screening tool. For specifically for brain injury. Oh, I guess that makes sense. I don't know of a specific one. I think there's a lot of Anastasia, you might have more information about like the Ohio.
Yeah, absolutely. There is it's from the Ohio State University Traumatic Brain Injury Model System, and there's several variations of a very brief screening tool that asks people to recall through prompts if there's been a time in their life when they've had a traumatic brain injury. And Dr. Corrigan, one of the creators of that tool, and it's evidence-based, it's been validated over many years, includes questions. There's a version that includes questions on acquired brain injuries, including overdose. So that is something you can definitely get from NASHIA or get from Laura or I. It's out there on the internet as well. So feel free to reach out and we can tell you how to get hold of that. Yeah. I'm sorry, go ahead.
No, go ahead, Tisha.
I was just going to say there's also some tools that people like Dr. Corrigan and other brain injury experts recommend, substance use screening tools that are more cognitively accessible. So that's something else too that we'd be happy to share with you. like the brief mass, the short or the brief Michigan alcohol screening use. So there's a few of them I've collected over the years as I hear folks like that recommend them. There is a question. Anna has the same question that I was going to ask you to expand upon about xylazine and how prevalent is it in the drugs that you've seen?
That's a great question. I think, I think sometimes we can get caught up in being like, this is the next scary thing, as a kind of way of like continuing this idea of like drugs as being like very scary. And obviously they can have a lot of side effects, but I think that there's been a pattern in the news the last few years of there being kind of like a new adulterant that's popping up every so often that is like has its own set of risks. So I'm not quite sure what the prevalence of xylazine is. I know that several of the clients that I work with at my syringe exchange have experienced xylazine or who have come in and saying things are feeling different and are describing symptoms that seem more consistent with xylazine. So xylazine is a non-opioid adulterant. It's often now cut into the fentanyl supply. I know that it's most common on the East Coast. So seeing a lot of it in like Baltimore City and Philadelphia and places like that. And Boston. Yeah. So I mean, I think that the biggest risks associated with it, I think, are that you have to use more frequently. There's like a higher, it like clears your system pretty quickly. And so people are using more frequently throughout the day. And then it also is, it doesn't respond to Narcan because it's not an opioid. And for me, I think the biggest thing that we've been struggling with at my syringe program has been the wounds. Like there's just been like a lot more wound care than we had 2 years ago. So we have a nurse from the health department who comes to needle exchange with us and who has been doing a lot of wound care with our clients because I think, yeah, we're just doing a lot more wound care than we were a couple of years ago. And I feel like almost everyone we're seeing is coming in with wounds like that need to be like dressed or treated or things like that. So I'm not sure how xylazine has affected the rest of the country, but for us, I know in our services, we're specifically looking at it around that wound care piece.
Thank you, Laura.
Yeah, and it seems like there's a lot of information in the chat about different people's experiences with it. Yeah.
I know it's come up in Maryland, added to like methamphetamines and cocaine. There's all kinds of stuff that seems to be popping up. So people are talking about it more.
Yeah. Well, thank you everybody for joining. I love to talk about brain injury and harm reduction. So I always appreciate the opportunity to get to share some of my experiences and learn from other people and just like be able to bring this. I think allowing us to complicate situations a little bit more has been really nice. So I appreciate it. Thank you to NASHIA and thank you to Sisha, Maria for inviting me to do this. And I am definitely interested in connecting with anybody who wants to talk about this more. I think I put my work email and my personal email in the chat, and please feel free to reach out to me.
Thank you, Laura. There's so many comments coming in. I'm trying to keep up with them to make sure we didn't miss any questions. I think you've answered them.
If there are some questions that you guys, want to share later on, or send my way, you certainly can, and we can put those back out and have them posted.
Thank you, Maria.
Cool.
And we can capture the resources in the chat as well. Do that now.
Yeah, thank you everybody for being so active in our discussion and really asking some pretty thought-provoking questions. These are great. And comments. Laura, thank you.
Laura, really, thank you. I mean, she makes it seem very easy, to take this field of practice on, and it's not. She's been devoted to this area for quite some time, and it shows your passion and commitment for what you're doing. Thank you for sharing all of that with us.
Thank you.
We appreciate it. Just a few things before we close out today. We hope you enjoyed today's event and this series. And you can join us for any of the other training events that we host, as well as any of the products, podcasts, or leading practices academies that we host. Here is a list of upcoming training events for you to put on your calendar. So stay tuned for some of those. And certainly we'd love to invite you to attend our State of the States conference. That will be September 11th through 14th in Minneapolis. If there are any questions, you can send them my way. Thank you for joining us today and viewing the webinar. If you'd like to receive notice of future events, you can let me know. And all of our webinars are archived and available online. Don't forget to complete your evaluations when those come to you in your email. And thanks so much. Have a great day.
Thank you, Maria. Thank you, Laura. Thank you,
Thank
everyone.
you both.